Yay, that was sizzling, wasn't it? Do you want to give it a clap and a clap of encouragement? And that was, I was giving a slightly misleading guideline, but you'll see as it unfolds. Look, ladies and gentlemen, this is called The Pitch, and for those of you who haven't been part of this before, it is absolutely thrilling. It's cruel that Teresa Anderson isn't here, but can't you feel her somehow in the room? You know? So what happens now is that some people are competing for $100,000 in real time, and that's exciting. Since 2014, the pitch has attracted over 200 entries from over 50 separate sections of Sydney Local Health District, and over $1.5 million has been given away to successful applicants. I think you should clap all that because that's pretty amazing. I'm going to quickly introduce you to the judges because you want to know who's making the decision to hand out the money. I would want to know if I were you, and it's got to be transparent. Then I'll tell you the rules and then we'll take off like a rocket. So thank you to our judges for this weighty responsibility. Our judges are the Honourable John Ajaka, the Chair of the Board of Sydney Local Health District, a lawyer, a politician and an active member of the Lebanese community and a million other things. Please make him welcome. Welcome also to Adjunct Professor Mary Haynes, a board member of Sydney Local Health District, a Fulbright scholar, PhD in public health, 20 years experience at senior levels in every health sector, including currently at the Menzies Centre for Health Policy and the Sachs Institute. Please make her welcome. Dr Mona Marabani, a rheumatologist, Head of Medicine at Canterbury Hospital, past President of the Australian Rheumatology Association and Arthritis Australia, and she's served as Principal Investigator in a private clinical trials unit for many years. Please welcome Dr Mona Marabani. Welcome also to Professor Ian Cateson, 51 years of service to health. Woo! Stand up! He's a Senior Staff Specialist in Endocrinology at Royal Prince Alfred and Medical Lead of the RPA COVID Vaccination Clinic, and he evidently knows everything about obesity. I'm afraid it didn't slow me from tucking in to lunch, but I tried to focus on the kale, which is currently in my teeth. And I'd also like to welcome two more judges, Elaine Duddy, I hope I'm pronouncing that correctly, thank you, Head of Customer Engagement ICT. And Elaine has 15 years of IT experience, including with Singtel, Optus, Telstra, HP and Qantas. Most excitingly, she was born in Coonabarabran. And you came over from Qantas and you've come back to us, and we thank you for it. So another round of applause for Elaine. And finally, Kyle Harvey, Acting Executive Director Operations. Look, I know nothing about Kyle. I met him at the Women's Leadership Group. I'd describe him as a very bright young man who gets things done. So would you make him welcome? So I'd like to invite Sarah, my beautiful assistant, who's now going to be a timekeeper, to take her position in the chair, because I'm going to tell you the rules, also how to vote for people's choice, and then we'll begin. So here are the rules of the pitch. As I said, $100,000 on the table to be won. Each person has 5 minutes, or each pitch, because there's some who have two people. Each pitch has 5 minutes in total to present their idea to the judges, and we will ring a bell at 4. I'm sorry if it interrupts you, I'm just got to do it to be fair. I'll ring a bell at 4, and then at 5 it'll be a cacophony. And immediately after that, the judges have 2 minutes to ask questions. And again, I'll ask the judges to have 1 or maximum 2 questions so we share that, and I think we've got people taking responsibility for that. So that's the format. 4-minute warning bell, 5-minute finish, 2 minutes questions. And we will hear the winners before we go to afternoon tea. One of the judges will come up and tell us. Now listen up, people's choice. You are able to vote by opening slido.com, and all the speakers, once all the speakers have spoken, you can open Slido. Someone tell me the password, please. Is it hashtag innovation? I can't hear you. Thank you. You open slido.com and then you enter #symposium, and that will enable you to vote. So be thinking about that all the way through. I'll let you know when Slido's open. We don't open it for that vote until everybody's spoken for obvious reasons. It's my pleasure now to say that the first pitch, the topic is the pain of falling is the same in any language, a multilingual fall prevention video. And I'd like to welcome Charlotte McLennan, Inpatient Falls Research Manager at the Institute for Musculoskeletal Health, and Wendy Tilden, Falls Coordinator. Please make them welcome.
So thank you everybody for watching our little video clip and listening to the story about John. So 44,000 people in Australia, in Australian hospitals, fall every year. And stories like John is just continuous that we want to stop, really. It's devastating for patients, staff and family. In our hospitals across our district, last year, 2,640 people fell. Our district has a rich diversity of culture and language, and in fact 54% of people in our district speak a language other than English at home. In terms of high quality research, evidence for falls prevention, education has been found to be the only strategy which really has shown consistent results to prevent falls in the hospital setting. We know that video is a cheap and effective way of delivering an engaging and consistent messaging, providing access to all. There was a large trial in Western Australia and it was undertaken in a rehab setting, and they used a video education for their patients. The results were incredibly successful over a large amount of people. So we have been interviewing Sydney Local Health District staff, patients and families to get their views to see whether this strategy could work in our acute hospitals. So these interviews, what people are telling us, that they would really like a falls prevention video and it would be well received, but to be most effective, the video should be relatable and engaging and use language accessible to all, and especially our most vulnerable people in our district, those who speak little English or no English at all, those with communication problems or cognitive impairment. So our consumers also want to have a video that's accessible to themselves and in their own language that they can have on their own devices.
So how will we achieve this? First up, we'd use the information from our interviews and from the literature to create a video and translate it in as many key languages as our funding initially allowed, with a plan for more translations over time. We'd work with partners such as Juntos Marketing, SLHD or Sydney Healthcare Interpreter Service, ICT, Strategic Relations and Communications to help achieve this. We'd then need to market our video to ensure it's embedded as part of routine care across wards of all hospitals in Sydney Local Health District. We'd work with district and local champions, falls and cognition committees, and to coincide with the release of the new SLHD Falls Prevention and Management Strategy to help us achieve this. We'd also need to evaluate our video to ensure its real-life impact and transferability. Falls prevention is a current district quality priority, and the Clinical Governance Unit are working closely with the Institute for Musculoskeletal Health to implement and evaluate falls prevention strategies. This partnership will ensure really rigorous evaluation of our video through methods such as quick viewer ratings at the end, number of views per language, interviews and surveys, looking at district falls rates, and through including the video as part of an implementation package in a planned upcoming clinical trial. So far, we've mentioned just some of the numerous stakeholders involved in our project. They'll be crucial to its success. Falls prevention really is everyone's business, and so we'll continue to engage with these groups and more to help reduce falls in our hospitals. Now down to financial business. Falls in hospitals are extremely expensive. Just one patient fall is associated with a mean increase in length of stay of 8 days and $7,000 in extra costs. Considering these figures and our district falls rates, falls in hospitals are costing us over $1.5 million every month. So we're requesting just over $12,000 to help create, translate and market this video that could be used for years to come. So once again, help us prevent stories like John's and the thousands across our district each year through funding us to create and translate a falls prevention video. Thank you. Whew, got there in time.
Thank you very, very much. And we have 2 minutes. If we could start 2 minutes for judges' questions. Thank you.
Thank you. Where exactly, you've said on their own devices, how are you going to get it to them, and will it be available in hospitals?
I missed the last bit of the question. So we ideally would like it both available on their own devices, but also through the intranet, and so it could be used on hospital devices like WOWs or ward iPads that are increasingly available since COVID. We'd anticipate that there'd be a QR code to link to the video in things like the patient compendium and on posters around the wards. And hopefully through a lot of our staff frontline education, everyone would become aware of the video and direct patients towards it.
Any other question? You maybe whip your masks off if you can. I probably shouldn't say that.
I'm especially interested in the cognitively impaired patient who are the people who are going to be very prone to falls. So what work has been done in the background about those patients and what sort of messages you might be able to effectively deliver to them?
So we've purposely trying to interview patients and their carers, those with cognitive impairments, to work out, the best way to reach them via a video, and working closely with the dementia CNC and things like that. We're seeing, when you look at some of the evidence in falls, some of the more promising studies definitely involve carers in the interventions where they try to reduce falls in the hospital settings, and so really encouraging visitors to know about the video and carers to know about the video, especially for our cognitive population. And the bonus of a video is that it could be shown multiple times to those with cognitive impairment, so it's not relying just on one-off education from a nursing staff or an allied health or medical professional, that it's there for them to watch as many times as they need.
Look, there's only 4 seconds left. Can I just use it to acknowledge that Charlotte is pregnant with twins? I would describe it as heavily pregnant with twins. So would you give Charlotte McLennan and Wendy Tilden a warm round of applause? Well, ladies and gentlemen, it's now time for the second pitch, and the topic is establishing an ADHD e-learning module to facilitate shared care partnerships between primary health practitioners and specialists in New South Wales. And we're welcoming Alicia Montgomery, Staff Specialist, Sydney Institute for Women and Children and their Families, and also Clinical Research Nurse Megan Taylor. Please make them welcome.
Hi everyone. So we are really delighted to be here to present to you our pitch to establish an ADHD e-learning module. So before we do get started, we have a really important message from some of our key collaborators, Jethro and Ivy.
Hi, I'm Jethro.
And I'm Ivy.
Today I'll be talking to you about ADHD. We need doctors and nurses to know about ADHD so that more kids can get the help and care they need.
Lots of kids have ADHD. It's very common. Did you know Nearly 5,000 kids have ADHD in our district. ADHD costs Australia a lot of money every year.
ADHD makes everyday life much harder for kids. It affects learning and also friendships. But there are lots of ways that kids with ADHD can be helped. So what's the problem? We don't have enough specialist doctors for all the kids with ADHD who need help. Professor Henry saw that things really need to change so that kids can get help quicker. In other countries, GPs and nurses play a big role in the care of kids living with ADHD. We'd like them to get more involved in ADHD here too.
Getting advice for ADHD shouldn't be as hard as it is right now in our state. And it shouldn't be the luck of the draw.
Specialist doctors are working really hard, but they are in high demand, so kids are having to wait a really long time for help. If GPs and nurses start to do more work with the kids with ADHD, we want to support them so kids get the best care possible.
Help us help them by funding our project to create an online learning program. Thanks for listening.
Thanks, everybody. So the New South Wales Health 2019 Henry Review of the state of paediatric services in our state highlighted ADHD as one of its key priority areas, both in view of its high prevalence, significant cost to society, but also in view of very significant challenges to accessing care statewide.
So in the SLHD, we are feeling this now more than ever, having seen a 47% increase in community paediatric outpatient referrals prior to the pandemic between 2017 and 2019, and quite a lot for ADHD.
Our team have been very active in advocacy at the ministry level around this issue and led the formation of a large collaborative group that were setting out to co-design a model of shared care that could be piloted statewide for ADHD in our state. We are leading several formative co-design studies and a systematic review of models of care for ADHD, and development of an educational program to support this work is the logical next step.
So with the support of our district, our department has experience in successful development of e-learning modules for GPs. So our team previously developed the Well Child Health Program, which has CPD accreditation with the Royal Australian College of GPs.
Our systematic review of ADHD models of care highlighted some of the key components of a successful integrated care approach to ADHD. These are shown on this slide, but first and foremost, it's clear that for shared care to succeed, we need a strong educational foundation so that all members of the team feel confident in their clinical approach. With that in mind, we are setting out to develop an e-learning module, which will be evaluated in partnership with GPs, paediatricians, nurse practitioners, and registrars, and psychiatrists.
So pre- and post-course evaluation of knowledge and confidence, in addition to user satisfaction and feasibility, will be conducted. We anticipate an increase in expertise and confidence pertaining to ADHD management among clinicians and increased participation in ADHD care.
We have an impressive range of key collaborators involved in this work, and our key partners on the educational piece are the Agency for Clinical Innovation at the Ministry, Hetty's General Practice Division, and the Australian ADHD Professionals Association Board.
So this project will leverage off existing expertise and relationships to facilitate a turnaround within 12 months. We already have existing content ready to adapt for this project.
We have significant buy-in from our existing collaborators to ensure that this resource will have both local relevance and also statewide influence, in addition to college CPD accreditation. Thank you.
Right on time.
Very impressive timing coming in, absolutely spot on. So we have 2 minutes of questions now, please, from our judges.
So in terms of that timeline, how successful likely do you think you'll be able to do it in that time frame? It looks very ambitious to do it in such a tight time frame.
It is ambitious. We probably have the benefit of the pandemic behind us, so a lot of this work was put on hold, but a lot of our key collaborators have been toiling away and doing some formative work around this topic over the last 2 years. We have a lot of existing content that's ready for adaptation, so we're not reinventing the wheel. We've got a lot of in-kind support from ADPA, the ADHD Professionals Association, and the Ministry, and so we have existing content that really just needs to be adapted and finessed into a final product.
I've got a question. So I can see that there's budget around the development of the video and the content. Has there been any thought around how people access the technologies, platforms to be able to use your platform?
Yeah, so we are certainly looking in the short term for hosting within the district, and we have a lot of very key collaborators on board with this project who will be involved in promoting the resource. Ideally, what I would like to see is that we create something that has statewide relevance that will be promoted by the Ministry and part of the rollout of shared models of care for ADHD statewide.
Yes, one quick one, thanks.
Yeah, this is going to be directed to GPs. How are you going? Have GPs really been involved, and how are you going to get it to them?
So we are partnering with the Rural Doctors Network, and in particular John Kramer, who is a GP who has really, I think, in New South Wales led the way in GP leadership in this space. We've also partnered with May Sue, who is the GP General Practice Academic League at HETI. So they're probably our two key collaborators, but we have also spoken to a lot of local GPs who are in clinical roles,
I'm sorry, I'll have to come in for fairness reasons, but thank you so much. Would you give Alicia and Megan a warm round of applause? And just before I introduce our next speakers, just being mindful of the hearing impaired, could our judges make sure the microphone is close to their mouths? And if you're speaking there, you don't lean in, but just come a little bit closer and shoot over the top with a little bit more volume. Am I with the 67-year-old who needs to hear, but I can't be alone in the room. So, ladies and gentlemen, our third pitch, very exciting. Fathers, are they the forgotten parent in NICU, Neonatal Intensive Care? And I'm welcoming Dr. Mark, how do I pronounce your surname, Mark? Greenhouch. Thank you. Dr. Mark Greenhouch, Head of Department, Neonatal ICU at RPA. Please make him welcome.
Good afternoon, everyone. Thanks for this opportunity to pitch this support package for fathers to you this afternoon. Many of our families have given us some of their images to share with you this afternoon, and I'm sure you'll thank them with me afterwards. The Neonatal Intensive Care Unit is a statewide referral unit. We look after some of the smallest and sickest babies born across New South Wales every year, and clearly a key focus for us is how we support these brave mothers in what is a long and often very traumatic journey. But to be truly family-centred and family-focused, how do we include the dads? These are a couple of our dads. I took these last week, these photos. They've just come in after work. They want to be included. Nobody wants or asks to have their baby in a neonatal ICU. We've got to work out ways where we can support dads. This is not an issue specifically related to RPA. This is a survey released by the WHO last year, which shows that the COVID pandemic has only widened the gap between mothers and fathers being involved in neonatal units. You can see on the right there from South Africa, my husband saw our baby on the day of birth and then again only on discharge, day 28. This 2 weekends ago was the sickest baby in New South Wales. You can see we've been able to support the mum over the first couple of days. She's sitting in the background expressing, she's confident, she's watching her baby, but she's watching her husband's heart breaking there. He's over his daughter, holding her hand, willing her on to get better. We know from the research there's several factors which influence how fathers are involved. Of course, how small, how sick their babies are. But the bottom two there, we can change the physical environment and how we support socially dads. I love this photo. This dad's a fireman. He's one of our fathers at the moment, and my colleagues helped me on the weekend get this photo, so this is why my pitch presentation was lately submitted. He's holding his preterm triplets, son on the left, daughter. Clearly, the role of fathers has changed. This is kangaroo care, where we take preterm babies out of their humidity cribs and give them to their parents to hold. These babies have better short and potentially long-term outcomes, and we need to have a father-friendly approach. This pitch has 4 components based on some quality improvement work we did in 2020. It's around developing resources directly focused to fathers, hosting a weekly fathers group, developing education packages for our amazing staff in our unit, and updating images around the unit and around the hospital to show that it's normal and totally okay for dads to be vulnerable. We have some measurable outcomes, including the incidence of kangaroo care that dads are doing, and we would love all dads to be doing that, regardless of how small your baby is. Even if your baby's 600 grams, I'd love for dads to be holding their baby in the first 72 hours. And of course, attending our fathers group and feedback from our staff. I thank Little Wonder, which is our parent support group, for putting us in touch with some dads, but also some mums that are really keen to see fathers better supported. We have a large multidisciplinary team that are keen to be involved as well. We have a very brave, but I think very achievable timeline, and I look forward to receiving my invitation to Symposium next year to tell you of our results. Kyle? Look, I don't need 100 grand, but I probably need about 10, maybe a bit over 10, and a large chunk of that is working with our communications team to develop some video resources in a few different languages, easily accessible, hosted on the website, directly related to dads. We've worked with comms before. We have an introductory video for parents that we show them before they have a baby in the unit. Go and have a look at our website to see some of the great things that happen in a NICU every day. Of course, dads love food, and we need to give them some refreshments and some other digital material around the unit as well. This is very easily transferable to PEDS ward, to the parent-baby unit, to my colleagues at Canterbury, and throughout our network within New South Wales and over Australia as well. Thank you very much.
Fantastic. Thank you, judges.
Great presentation, Mark. Thank you. Obviously, our district serves quite a diverse family groups. Has there been any consideration of other family dynamics in this program?
Yeah, totally right. We have a 99.9% female-dominated workforce in paediatrics, and especially in the neonatal unit. And our workforce is very comfortable working with mums, and often 2 mums. And we can certainly work really well, I think, with embracing the different dynamics of families that we see in the neonatal unit. I think fathers specifically need a real focus. So this isn't about segregating same-sex couples by any stretch, but I think we embrace that already in our district and certainly in our unit. This is aimed specifically to dads.
And another question here. Thank you.
Thank you. My question is about the sustainability of this. What you're proposing is a video and ongoing weekly support groups. So if we invest the $12,000 now, how much is it going to cost on an ongoing basis thereafter?
Yeah, so it's only 10.5, so I'll give you 1.5 back.
Why, thank you. I'll go shopping with that.
Yeah, so look, this is a pilot just for the first 12 months, and I suspect once we can show that this is highly valued, we'll be able to seek support external to the district to keep this rolling forward. But clearly, the generation of resources is a really key fact. We can do that within the district. We just need some help getting that going.
Look, thank you so much. A big round of applause for Mark, please. Well, ladies and gentlemen, our fourth pitch is MyVLED app, supporting patients in obesity management. And I'd like you to welcome Associate Professor Samantha Hocking, endocrinologist, endocrinology, Royal Prince Alfred Hospital. Make her welcome. Thank you.
Thank you very, very much for this opportunity to present the MyVLED app, which we believe will support patients attending the Metabolism and Obesity Service beyond the hospital. Obesity affects 1 in 3 Australian adults and increases the risks for a number of chronic health conditions. And because of this, it's associated with very high healthcare costs. Over the last 5 years, a number of landmark clinical trials have shown how effective very low energy diets or total meal replacement diets are in assisting patients with obesity with weight management. Shown here are the results from the Droplet trial, which showed that a brief 6-month very low energy diet intervention resulted in successful weight loss of over 10 kilograms at 12 months. At the Metabolism and Obesity Service, we have been using very low energy diet programs for a number of years to assist our patients with obesity with weight management. And we have been delivering this program in a face-to-face group setting to provide patient education and the opportunity for peer support. Unfortunately, the COVID-19 pandemic disrupted our service and our ability to provide this in a group and face-to-face setting. And in fact, the COVID-19 pandemic highlighted just how at risk our patients with obesity were, and they are a very vulnerable group to severe infection with COVID-19. So we were forced to transition our service to telehealth. And we did this very quickly and moved to a video conferenced, group-based patient support program. This allowed us to continue our service, but did add a large administrative burden to our clinicians. In addition, although we asked patients to self-report their weight and ask questions at the time of the fortnightly sessions, many did not, and this led to a large amount of time spent chasing individuals to monitor their progress. At the other side of a video conference, it's also very difficult to ascertain whether your patient is remaining engaged and difficult to identify patients who may need individual support. We didn't want to be talking to a number of zombies. So our proposal is the MyVLED app. This app can provide patient education and the answer to frequently asked questions. In addition, it enhances patient engagement by allowing them to set their goals and also to track and monitor their progress using the features of the app. We can continue to support them through app notifications and automated reminders, reducing administrative burden. One of the key features of this app is this clinician dashboard. This allows the clinician to have an overview of the entire patient group on a single screenshot. By flagging out-of-range results or results that are not entered, we can determine which patients are not adhering to our program or not meeting their targets. And this allows the clinician to quickly identify those patients who they need to reach out for further support, which saves clinician workload. So our proposal is to first customise an app specific to our VLED program. We will then conduct a 12-month pilot intervention study and then evaluate the program to see whether it is successful and should be embedded in routine clinical care at the Metabolism and Obesity Service. We will measure our success by comparing our current telehealth VLED program with and without the app. Our primary outcome measure is patient and clinician satisfaction. We will also measure patient engagement and retention, and of course the effectiveness in terms of weight loss and safety outcomes. We will embed a cost-effectiveness and implementation study into our pilot program. Our key stakeholders, of course, are our patients and clinicians, who have shown us that they can very quickly adapt to digital health technology through COVID. We have chosen Volson as our app developer as they have already developed apps used by New South Wales Health, and you have seen screenshots from those apps throughout my presentation. The SLHD will be a partner supporting this pitch, and we will apply for enhancement funding if we wish to continue with the app. As I mentioned, we will need 18 months for this, 3 months for app development, our 12-month implementation and then evaluation, and our budget is modest at $15,000. One of the other key features of this online program and app is that it can be extended to other departments within the SLHG that treat conditions that would benefit from weight management, including type 2 diabetes, non-alcoholic fatty liver disease, obstructive sleep apnea, and heart disease. So our VLED app will increase patient engagement and satisfaction. The remote monitoring will alleviate clinician burden. We believe it's scalable and cost-effective and is adapted to many departments within the hospital. Thank you for your attention.
Thank you so much, and we have a question here.
Look, thank you for that presentation. Is 15,000 realistic? Looking at all that you want to achieve, are you able to do it over the 18-month period with 15,000?
We are, and the reasons we are is that we don't have to develop a new app. So many of the features of this app already exist and are already being used by New South Wales Health. So we're not developing a new app, we're just simply customising an existing app. And we're also doing it with a partner through the University of Sydney. And so they're very keen to do apps for New South Wales Health for the future of their business. So they're willing to do it for the $5,000 cost. In addition, we're hosting the actual app through Amazon, and they do have grants for not-for-profit organisations to reduce the cost of app hosting.
How do you know that the patients are going to want to use this? Are there studies showing that apps are, for your patient group, what the acceptability, uptake and effectiveness is?
Yeah, that's a great question. So there are a number of weight loss apps, and everyone would be familiar with them. You only have to look at the App Store. And their uptake is very good. They're not quite so good when they're not facilitated by a clinician. So the fact that this is not an app-delivered program, it's simply a facilitation of an online clinician-delivered program will make it more successful. And our colleagues in the Department of Diabetes have used an app in one of their recent projects with young adults with type 2 diabetes, showing that it was highly effective and it also reduced administrative burden.
How are these judges going to choose? That's so interesting. Would you please thank Associate Professor Samantha Hocking?
Thank you.
Golly. Well, ladies and gentlemen, our final pitch this afternoon is a matching piece to bowel cancer supportive care. And I'd like you to welcome Dr. Michael Suhan, Staff Specialist at the Colorectal Department at Concord Hospital. Please make him welcome.
Good afternoon, ladies and gentlemen. There's a reason why I dress up like an IT person today rather than like a surgeon. So it's my great honour that I can share some of my thoughts or our group's thoughts on how to improve bowel cancer care to all of you today. The minute when bowel cancer is diagnosed, it is actually a very busy and chaotic process. Now, patients need to see multiple specialists and they get overloaded with information. So bowel cancer cure is usually the primary focus in every single part of this mechanism. In the last, it is actually, this very complicated process, not surprisingly, is in fact full of loopholes and potential inefficiencies. In the last 10 years, the colorectal unit in Concord Hospital has been focusing on improving the perioperative component of this process by implementing two system and cultural change initiatives, namely ERAS in 2013 and prehabilitation in 2018. These two initiatives have successfully achieved reduction of length of stay, complication, staff workload, improved system efficiency, and cost savings for our district. We even now become the study role model for the ACI Surgical Task Force in New South Wales. So the audience might ask here, so what else is actually missing in this process? Currently, all the perioperative care is actually designed to prepare patients' physical readiness for surgery. However, they are not designed to prepare their readiness for recovery. Clinicians are often too busy in a short consultation to try to address anything more than their cancer care at present. Now, I want the audience to remember this 40 number is a magical number for actually bowel cancer recovery. 40% of the patient functionally not recover to their baseline after 2 months. 40% of the patients suffer major bowel dysfunction called anterior resection syndrome after their treatment. And not surprisingly, less than 40% of patients return to work by 1 year. I'm sure you all had online shopping experiences when you had seen a product that you never seen and you don't know what is the quality of that product. So you're very puzzled what you expect to get, right? So the video content in the internet at present is actually a great tool to assist buyers' purchasing expectation. Our group actually want to replicate this experience and try to innovate our current rehabilitation process by adding digital content that is patient-centered, easy to digest, on demand with live demonstration to actually improve information retention. Now, the pitch here is a great forum for me to present this idea to you today. As I have to say, this is much needed innovation. It's a bit hard to fit into a traditional research grant model. Our team is seeking to develop a purpose-built, professional, informative, modernized digital content on bowel cancer recovery that hopefully will align with our district's virtualization vision. Now, after discussing with the initial discussions with key stakeholders, we identified 4 important bowel cancer recovery topics that is important, and we want to develop digital contents around those 4 topics. And we want to aim to narrow patients' knowledge gap and trying to assist their recovery expectation. Yes, indeed, our project is about making a movie about bowel cancer recovery. But the goal here is actually to have a patient that is better prepared for their cancer care. We have already written a storyboard. We have already written video script, feedback from consumers, and getting professional consultations from video production individuals to see what is achievable. And what I need now is your support and your funding to make this initiative achievable. Now, it is actually a great investment because you don't just own, but you can watch the product once it is finished. And there are many measurable online and offline measurable outcomes to measure our success. There are many key stakeholders, but what I need to obtain is buy-in from you, our district. Now, we expect this video will finish production in about 6 to 10 months. And most of our funding that I'm seeking today will go into the video production. It is highly sustainable because we have endorsement by all key stakeholders. It is highly deliverable because it will be delivered by the existing colorectal and rehabilitation team member. And we envisage this will become the new enhanced rehabilitation program 2.0. Now, it is highly transferable to other colorectal services. It is easily replicable by other surgical services. And it can be utilized both in the metropolitan and in the remote setting. Bowel cancer care should be holistic, collaborative, and patient-centered. And to achieve this is like putting jigsaw puzzles together. Our group needs your support so that we can get support from this new matching piece that we identified so that we can continue to pave the way to improve bowel cancer care for our patients. Thank you.
Thank you so much. Thank you so much. And we have a question here.
Thank you, Michael. That was a wonderful presentation. Could you tell us about the patient's involvement in the development of this story?
Great question. So allow me to steal these 2 minutes. So this is actually a feedback from a patient that I don't have time to put into my presentation. So the feedback says, these videos are so valuable, and I wish I had access to them for my surgery. They are a fantastic idea for us poor patients who are so in the dark when we arrive in theatre for surgery. I hope I answer your question.
Another question, thank you.
We've heard before around the different languages that we need to support in our district to the diversity of our patients. Have you thought about the language?
Another great question, yeah. Okay. So now, why we're not talking about other languages is you'll be amazed. So in our group, there is actually a UK correspondent or a UK consultant. So his comment is, there is actually no education video for bowel cancer recovery in UK. And there is actually no literature about educational videos for cancer care before cancer surgery in Australia at present.
Oh my God! Look,
That's why it is called a pitch.
I don't know what you're going to do, judges. Please thank Dr. Michael Sewin. Thank you.
Thank you.
Thank you all. What a wonderful conference we've been having. The goal of Sydney Health District is excellence in healthcare for all, and innovation is absolutely why we can do that. We can strive for excellence because of innovation. And I think this pitch today is the epitome of the innovation that's within the DNA of this district. So, we had 5 fantastic presentations, some irresistibly good ideas. My co-judges found it really, really hard to choose the winners, and we've landed on 2. The first, thankfully, aligns with the People's Choice. I'd like to invite Dr. Mark Greenhalgh up for the Fathers in NICU. Mark has been awarded $15,000 to take account of the People's Choice vote, but also because the judges felt that he probably needed a little bit extra as well to help with his outreach. So congratulations, Mark. Congratulations, Mark. And the tied other first was Professor Samantha Hocking with the MyVLED. Congratulations, Samantha and team. Wonderful innovation, and I must note that the judge, Ian Cateson, absented himself from the discussions on this. Fantastic, Samantha, thank you. And as I said, the judges found it tremendously difficult to choose these 2, so we'd really like to congratulate the other 3. And the board, through the executive, will be providing linkages and assistance to those other 3 to try and support the progress of their ideas. A big round of applause for the other 3, please. And finally, those of you that put in applications but weren't shortlisted for the pitch, keep applying. Innovation is in the DNA of this district. And remember that every masterpiece started as a first draft that got reworked. So keep applying. Thank you.